Now I'd like to introduce our next panel, which is focused on generating more opportunities for transplantation. We have three esteemed speakers with us today. Each will share their insights for about 10 to 12 minutes, and then we'll bring them all back together at the end to take questions about this topic from you. Our first speaker today is Howard Nathan. Howard is the president and CEO of the Philadelphia-based Gift of Life Donor Program, which is the largest and one of the oldest organ procurement organizations in the country. The group has coordinated more than 50,000 organ transplants, as well as 1.5 million tissue allografts since 1974. Our second speaker is Dr. Amit Mathur. Amit is an abdominal transplant surgeon at the Mayo Clinic in Phoenix, Arizona, and he's director of their Transplant Surgery Fellowship. He also serves as director for transplant quality and compliance at the Mayo Clinic in Arizona, and he's also co-chair of transplant quality and compliance for the Mayo Clinic at the enterprise level. And finally, our third speaker is John Gutowski. John is the executive director of the University of Colorado Hospital Transplant Center, where he oversees clinical, financial, operational, quality, and regulatory functions. His interests include cost containment and revenue enhancement, quality and performance improvement, and operational efficiency. With those introductions completed, I'd now like to welcome Howard Nathan to the stage. Howard.
Thanks, John. It's my pleasure to be here, and thanks everybody for the opportunity. I think this will be an extension of the talk that we just heard about from Dr. Snyder. This is called Leveraging What You Know to Generate Opportunities. And I just wanted to say one thing about what Richard had said about donors. Just to clarify, this year, we're on track to have 12,512 donors based on today's data, which will generate 36,658 organs transplanted. It's about a 5.5% increase in donation compared to last year, and about a 2.6% in transplants. And I think that leads us into the discussion that the donors that we're procuring right now are more complex donors, and there are less transplants per donor. Next slide. So this gives you the donation process, and everybody's familiar with the process, I'm sure. But one of the things I wanted to focus on, click please, is the concept of what does it take to get an organ to an appropriate recipient. And the idea is that once a patient's declared dead on a brain dead donor, how long does it take to get that process done till we actually get the organs removed? So I'm going to focus a little bit on that, along with some other things related to transportation, expense, and some other issues. Next slide. So this gives you the entire last 12 years or so on what the time is in median hours for OPOs to distribute all the organs from brain death pronouncement to the aortic clamp in the operating room. And you can see over time, it's increased and almost doubled in time on average. Next slide, please. This gives you just this last year and a half or so what it takes for each OPO, and what it shows is the variation in the number of hours from as little as about 26 or 27 hours from pronouncement to clamp to as long as 78 hours. And what that means is OPOs are taking longer, primarily because they're trying to place more organs with more complex donors. This is a big issue as time goes on, and we need to look at some of the technical aspects that can improve this. Next slide. We started out with this, a telephone in a man named Don Denny, who was a coordinator in Pittsburgh's office. It was an answering machine, and we distributed extrarenal organs because UNOS didn't exist yet for extrarenal organs, and in 4 years, we distributed about 2,500 organs. And the question I have is, have we changed much since then using the telephone and other things? Next slide. This is how we got the information. We listened to a recording, we wrote the numbers down and the weight whether a cross match was needed. And then we called the center and said we had an organ available. And they were prioritized 1 through 4, similar to what we had done in the past with UNOS. Next slide. Right now, the complexity in the donation process is unique to every OPO. So in some OPOs, the donor OPO calls the other OPO. They call the transplant center, or that OPO may call the third-party answering service, which then in turn calls the transplant center. The communication is complex depending on where you are in the country. And all the things that you see on the right, to take the call, calling the surgeon or the coordinator, accept or reject the offer, the transportation arrangements, preservation, etc., are different from place to place. And they can be very complex. Next slide. Just to give you an idea, in our region, you can see this is the number of calls, because Gift of Life still continues to take all the referrals of offers from UNOS for all 15 transplant centers in our region. So you can see in 2011, we had about 15,000 offers. And if you look at what is proposed for next year with the new kidney allocation beginning next month, we may be taking as many as 52,000 offers through our call center, or about 160 a day, or 1 every 10 minutes, to offer organs to our centers. Next slide. You can see, click once, click twice. And in general, and I think this is true for many places, 110 kidney offers results in 1 kidney accepted. 50 liver offers represents 1 liver accepted. So the number of calls that we get, there's a lot of noise in the system that we go through every time we are notified from UNOS. Can this be improved? I think it can be. Next slide. So with DonorNet, certainly it's enhanced having an answering machine in Dr. Hackela's office in Pittsburgh. We get notified now through the UNOS system, and we can then notify transplant surgeons or the coordinators or the third-party answering service. What we need is some of these things. Filtering for those candidates better than we have now. The idea of defining what's a provisional yes, and other enhancements that we need to make the system more efficient. Next slide. Get the organ to the right patient. That's certainly what we need to do, but we need to do it quicker. Next slide. So the rules of engagement really haven't been talked about. What's an OPO to do? What's a transplant center to do? What's that third-party answering service that many transplant centers use? What are they doing? And how's the communication between the 3 groups? Let me give you an example of how we tried to solve the problem in Philadelphia. Click. Click, please. We said a long time ago, let's treat the kidney like a heart. Well, what do we mean by that? Next slide. We looked at what it took to distribute a kidney in our region, and we had 6 laboratories to do final cross matches and didn't even have a centralized laboratory to do donor HLA. We changed all that about 25 years ago, and we began this process to look at what we needed to do to give a kidney away from the OPO standpoint, called renal distribution time, which included final cross matches, and then we gave the kidney away to the transplant center for them to transplant. Next slide. The HLA identification process started with peripheral blood. Blood was sent to all local and regional laboratories. Cross matches were performed by all transplant center for their top clean patients and their high titer, high point patients, so that the cross matches could be completed before we went to the operating room. Treat the kidney like a heart. Couriers were alerted, and they were present at the donor hospital to transport the kidneys directly to the accepting center. Next slide. And we decreased the time just in the last 15 years or so down to about 3 hours, meaning including final cross-match. And at that point in time, it's up to the transplant center to put it in. Next slide. What about cost? Well, this is a very complex slide that I created a long time ago to talk about all the different costs, and it's usually animated. But you have direct costs, from donor hospitals and transportation. You have your indirect costs of salaries to run the OPO. And then we come up with what we call a standard acquisition charge that then's billed to the transplant centers. Then, of course, the transplant centers bill the insurance companies. In some cases, the transplant centers have a cost that includes our cost, but other costs that we don't even know about. That's a whole other issue for OPOs. Next slide. So how are organ acquisition charged? With our system in Gift of Life, we actually have an import. We take the import fee from the other OPO, but we charge our local fee and just add transportation. Some OPOs pass it through from the other OPO and add transportation. Some add an administrative fee, and then in some cases, transplant centers pay it themselves and pay their own air transportation and do everything themselves. It varies from place to place. Next slide. Just to give you an example, again, a Gift of Life. In terms of the allocation changes for lungs, it began in 17 and then 18, and then now in 2020 with livers, we had an increase of 191 imports to now 321 imported organs. Next slide. More importantly, what did it cost? And what this cost is to the transplant centers, from about 2.4 million to about 4.4 million, or about an 80% increase in costs to get those organs from place to place. Next slide. And as I said before we went on live, in the East, it's a different story than in the West. We have now, for every kidney we procure, 63 transplant centers and 13 different OPOs that we're going to have to deal with if a donor is in Philadelphia. That's quite different than if you go out to Utah or Colorado or somewhere else. There may be much fewer OPOs, much fewer transplant centers. So the complexity is much more increased, I believe, in the East. Next slide. So it requires our increased call volume, increased staffing, interacting with more centers, and we're interacting with more unfamiliar surgeons doing retrievals and shipping organs from place to place. Next slide. So one of the concerns that we have, late refusals by transplant centers require allocation. And one of the reasons is acceptance of more than one organ for the same patient still occurs. We need to fix that. The potential for a longer pre-recovery time, as I showed. Potential loss of organs due to logistics. What about planes? What about weather? All these different things, as the travel is increased, particularly in a small geographic area, becomes a real issue. Next slide. Next slide. So we want to be fair to all patients. We want to be efficient, but we also have this complexity that we're dealing with. Next slide. So in summary, have the systems changed in allocation benefited all transplant patients? How do we achieve better efficiency? We definitely need better tools from UNOS to improve efficiency and allocation. How can we decrease the allocation time? And we clearly have increased costs due to travel and increased staffing. That's where I leave it, and look forward to hearing the other speakers. Next slide. My question has always been, are we just rearranging the decks on the chairs on the deck of the Titanic? That's a little bit presumptuous, I guess, but hopefully we're doing things to improve better patient care. Next slide, thank you. I'm going to now introduce Dr. Mathur from the Arizona Mayo Clinic. Dr. Mathur.
Thank you, Howard. Good morning or good afternoon, depending on where you sit in the country. My name is Amit Mathur. I'm a transplant surgeon at Mayo Clinic in Arizona. and I'm involved with the liver program and kidney programs at our center. I want to thank the Alliance for the opportunity to discuss our transplant program's experience and what I think is a highly translatable activity or feat, which is adapting to a super scarce organ transplant environment, as Howard had alluded to in the last talk. Next slide. I don't have any disclosures related to this presentation. Next slide. So what do I mean by the term super scarcity? Well, the organ transplant market, if you will, is the classic example of a high demand, low supply market. And because there are not enough organs to go around, there is scarcity. And so this is a problem virtually anywhere in the world. There's more patients with organ failure, and the supply is limited no matter what type, no matter where you are in the world. Now, if you look at U.S. liver transplantation, and most of my talk is going to focus on liver-related issues, we've actually seen growth. So as Howard alluded to in the last presentation, we're seeing more organ donation, and we are seeing overall for the system, and we're also seeing more transplants. Now, the reason why we're probably seeing a lot more in terms of organ donation is driven by the opioid crisis, and there's been a number of papers that have been published that have alluded to that. But this still isn't enough organs to really meet the demands. And so, you know, if you look at it at a system-wide level, you can see that there's about 12,000 patients on the liver transplant waiting list. About 8,000 liver transplants will be done. But, you know, that's at the system level, but you can think about it in your own program on a daily basis. We statistically add more patients to the list every day than we subtract with transplants. So, but now we actually have changed the rules. And so as a transplant community, we have created a broader sharing algorithm. We share organs, particularly in liver transplantation, out to 500-mile circles. And so for my program in Phoenix, we have a share threshold out to 500 miles down to a MELD score of 29. So for us, this virtually eliminates the ability to use local brain dead donors for anyone whose MELD score is below 29, which still includes a significant percentage of desperate patients, because we have programs around us that have very high median MELDs at transplant that are able to pull those brain dead organs to their patients. So on top of the broader sharing issues, we also have changed the way that a strong percentage of the list, how highly they're prioritized, and that's MELD exception patients. For example, 10% of the list of the liver transplant waiting list nationally is made up of patients with hepatocellular cancer. Those are MELD exception patients, and now they are deprioritized with median MELDs at transplant -3, depending on your center. And so those patients typically do not really have access to the higher quality organs that they used to have. So, and continuous distribution is coming around the corner, as there has been discussed in numerous forums and policy discussions at UNOS and nationally over the course of the last couple of years. So organs were scarce before, but now there are even more barriers to overcome and manage these new challenges. And so I think it's really important to understand that we have to adapt to survive. And that's what an organism does when the environment becomes one of super scarcity. Next slide. So everybody is familiar with Charles Darwin, who is the father of modern evolutionary theory. And he identified in his studies that certain traits for organisms, and one of the classic examples is the finches of the Galapagos Islands, that if they acquire certain traits, they are naturally selected to survive. And so similar to the finches of the Galapagos Islands, transplant centers have to adapt to this harsh reality of organ allocation. It is, there are less real organs effectively for any patient in any given MELD, particularly for lower MELD patients. And there are significant costs associated with using livers because they're going to travel more. And there's all kinds of relationship issues. So how does a program adapt? Next slide. So, well, there has to be a commitment to evolve. And so with the super scarcity in the environment, there are greater clinical challenges for transplant programs to use organs that they're not used to using. For any given, let's say, a patient with a MELD score of 25, the organ quality that that particular patient is going to get today in 2020 is vastly different than it was in 2010. And so programs have to be ready to meet those clinical challenges, and they have to be ready to address issues of cost. Travel costs, logistical costs are a very real reality, and Howard presented specific data on those issues, and John Gutowski, who's going to follow me, is going to talk about that even more. So there are clinical realities that programs have to get used to and to evolve in this environment. Next slide. So how do programs adapt? And I could talk for 24 hours continuously about how programs could adapt, but I'm going to boil it down really to kind of 4 major issues that we have found to be helpful in the Mayo Clinic program in Arizona. One is related to organizational and team culture. The other is our clinical philosophy. The third is how we manage relationships, both internally in the program and externally. I think my slides are, can we go back? I think someone fell on the keyboard. Keep going. All right, there we go. Next slide. So the third aspect is relationship management. And that is how we deal with internal relationships within the transplant center and transplant hospital, and external relationships. How do we interact with OPOs now in a new environment with OPOs that we may have never worked with before? And how do we interact also the relationships with our patients? How do we talk to them about the environment in which they are and what are their specific risks? The fourth aspect is how do we manage growth? And so I would argue that if the culture is right, the organizational culture is right, the transplant team's culture is right, that the right clinical philosophy exists, and the relationships are managed well, growth is inevitable. Growth is a natural consequence of having those aspects aligned. And so, but a program has to be prepared, even in this current scarce environment, for growth, and that's something that we've seen in our program. Next slide. So team culture and clinical philosophy. So I think that all winning teams talk about team culture, no matter what area of what industry you're in, whether you are the New England Patriots, whether you are a transplant center, you talk about team culture. And it is the easiest thing to talk about, but it is the most difficult thing to have. And because it is difficult to crystallize all of the things that go into that culture recipe, it's very difficult to understand the amounts of what you need. But I think a team culture is also driven by the organizational culture. And so what I mean by that is your transplant center in a healthcare system that is truly committed to your transplant program? Do they get it? Does the program, or does the hospital, does the health system understand what it takes to make transplant successful? Does that health system, are they willing to commit a little to get more? And making the business case for that, I think, is very, very important. But ultimately, I think it actually has to do with whether or not your hospital gets what your patients need and what their clinical commitment is to the transplant program. So in our case, we have always been committed to meeting the needs of our patients in any way that we can. So particularly for our waitlisted patients, how do we move the patient from a waitlisted patient with end organ failure to a post-transplant patient in the safest, most expeditious way possible? And so in the current environment, that would represent what happened a few years ago with organs really becoming less available in our local area when the share thresholds went down. They were at first at a share 35, now they're effectively at a share 29. And so our program was in a change valence that wanted to move toward change. And so we were ready for change. So what does change valence mean? Well, change valence is an organizational psychology term that refers to how in any organization or any team, what is the readiness for change and how valuable does that team see a change that is necessary. So in our case, getting our patients transplanted with non-traditional organs, with marginal organs, if you will, represented a significant shift in what we were doing. So, but our change valence was there, and I think that was driven by leadership. We have strong leadership on the medical and surgical sides, as well as at the organization level above the transplant center. And so everybody was ready to change. And I think readiness for change is going to be more or less successful depending on where a team sits with regard to that change. So if a team wants to change, they have a deep, passionate desire to change, then they will change. It's more easy to change rather than being told they have to change, or that they take a dispassionate or more apathetic view of that change and say, yeah, we probably should change, but then really don't have the organizational structure, incentive to really make that change. And so that's really, really important. There has to be alignment at the organizational level and with the team to make sure that that change is successful and that there is a passionate want to change. Next slide. So team culture, we wanted to do more transplants in order to address the needs of our patients. And so the way that we did that was by using aggressive deceased donor organ practices. And so John Snyder gave a great presentation that kind of summarized how our approach to transplant is. But as we evolved in this environment, our team dynamics evolved as well. And so again, we emphasize the philosophical alignment of the clinical program and growth, and we wanted to facilitate growth over other factors. So the commitment to the clinical program was the most important. When we designed the team and included more and more personnel in it, we emphasized the A's: availability, affability, and ability, but also adaptability. Adaptability was very important because we were building a culture in a program where the providers who were in that program all came from different places. And so adaptability was really important. Cross-pollination was really important. Being committed to each other in a culture of we was really important than the culture of I. And I think our medical and surgical team leadership really emphasized that, and the organization reflected that as well. Next slide. So clinical adaptation. So how have we grown in the liver program? Well, probably the primary way that we've done that is in utilization of donation after circulatory death donor livers. We include those for simultaneous liver kidney patients. We've used hepatitis C viremic organs, increased infection risk donors. We've also used living donor liver transplant. But I think that our clinical adaptation probably is most prominent in the structure and way we've designed the program. And that is we've designed the team intelligently. We've used internal procurement team nurse coordinators to process organ offers. And these individuals, we have a large team of them that process liver, kidney, heart, pancreas offers, really practice at the limit of their scope of practice. And then we've also separated out surgeon and physician roles that focus surgical effort in organ acceptance, or patient evaluation, and postoperative operative care, and then postoperative management, and the other management of patients in the long term has been completely borne by our hepatologists, for example. But I think we have continuous clinical engagement. I think we're always trying to make things better, and that surgeons, physicians, nurses are all together on the same page and trying to make the clinical program work better. I mentioned that the intelligent team design is contingent on team empowerment. People have to be able to practice at the very limit of their scope of practice and have to have leadership and a management team that really allows them to excel and commits to making sure that every individual has the tools that they need to do their job efficiently. And I think in order to inform that, you have to have broad attention to quality and quality improvement, which is an important part of what we've done in Arizona. Next slide. So pearls, we believe, have helped. Well, we have active knowledge and engagement with the waiting list. There's nothing like knowing your own patients, and in any blood group, I can tell you the patients and their issues at any given point in time. This is a required a commitment to making sure that we understand who's on our list and what they need to get transplanted in order to do that in an efficient fashion when a late reallocation occurs, for example. We also actively manage logistics. So our procurement nurse coordinators will manage organ offers, but we also have dedicated procurement surgeon effort and dedicated procurement time by our transplant surgery staff where they don't have any other commitments. And then logistic management also includes patient logistics. So where our patients live, how far are they away from the transplant center, what are their transport options? Those are actively discussed things at the time of evaluation and at the time of listing, and then in the ongoing period during the waitlist period. I think good principles in donor-recipient matching are critical, and this is informed by our own data. We know what works and what hasn't worked. We certainly haven't been successful in every single transplant, and we try to go back and look at those cases to figure out what we could have done better. And so I think, following your data for quality improvement is really important. Next slide. So relationship management. So within our hospital, there's, it takes a village to make this happen, but externally, the transplant team has to be committed to working with particularly OPOs and the OPTN and SRTR to understand what are the issues that are going to affect your ability to get patients transplanted and understanding their challenges. And then with the OPTN and SRTR, understanding how programs need to, how they're measured, so that way you can ensure that you continue to be successful. Next slide. So managing growth, this will be my last slide. I think that your organization has to understand the value of transplantation. And I think if your organization understands that, it can respond to your needs. Our model has been one of stable leadership and through trials and tribulations. And you can see that in our transplant programs from the inception at 1999 to where we are now. We are growing at a rapid rate, and there's a lot of commitment to the team. That means proactive staffing, frequent needs assessments, and then also the feedback from hospital vulnerabilities and resources. But I think managing growth is really related to making sure that you have a culture of yes, try to find a way to use organs rather than a way to decline organs. And I think that's something that's a deep philosophy of our program. Next slide. So this is a picture of what liver transplantation looks like in the United States. In 2020, using these principles, we are the busiest liver transplant program in the United States to date. But more than 3/4 of our organs come from not local sources, a high rate of DCD use, and the lowest median melded transplant in the continental United States. Next slide. I'll skip this one. We can talk about that in the Q&A. But in summary, I think it's really important for programs in order to evolve, have to understand current conditions and understand their partners inside the organization and outside to make more transplants happen. And just by committing to your list and committing to your patients, I think that can really be done. Thank you. With that, I'll introduce John Gutowski from University of Colorado. He is probably one of the most brilliant transplant administrators I know, and he's going to talk about the financial challenges of the current environment.
Good morning, good afternoon, everyone. Thanks for being here, and I look forward to presenting on a little bit more of the financial and operational details associated with some of these challenges that we face today. Challenges that we face even more in the current pandemic that we're in that make efficiency more difficult and financial stability even more of a concern for our health systems. Next slide, please. I have no relevant conflicts. Next slide. So we're going to talk about a few different areas here, travel costs, and break that apart a little bit more from what Howard had discussed earlier. Some staffing challenges, both within this new allocation world as with how those staffing challenges relate to the current pandemic and some of the challenges we face in the hospital system. We're going to talk a little bit more in depth about internal call teams, as my partners alluded to as well, some additional financial considerations, and then of course, there's always an upside. Next slide, please. Increased travel. This has become a fairly significant issue, and in a place like Colorado, we have to travel a lot further than perhaps those on the East Coast have to travel in order to procure organs. So we tend to go east as far as St. Louis, down into Texas, north into the Dakotas and Montana. We basically are flying almost a quarter of the way across the country on a regular basis. And private commercial flight availability, as Dr. David Axelrod has spoken about many times, has become more limited, and it's become significantly more costly. Our current OPO runs our commercial flights, and there have been times where we've had some issues getting flights out of our particular area, both for availability of those flights, but weather also becomes of difficulty for us in order to get from point A to point B. Pilot availability and the regulations that have been imposed on pilots. As Dr. Axelrod has said before, there's less pilots that are coming out of training to do this work. There's less planes for them to fly on, and there's regulations that are associated with how long their flight times may be, how long they can sit on a tarmac, etc. And all of that increased cost consideration really started for us in our thoracic programs, where we had a budget about 25% flyout. So if you look at a heart program of 40 transplants a year, we're expecting to fly about 10 times. If your average cost is $25,000 a flight, that's manageable at about $250,000. But as the allocation systems have shifted and where we're traveling to, our increase in cost has moved a little bit closer to the $30,000 flight range, and we're flying about 75% of the transplants that we're doing. And so we've added more than $500,000 to our existing budget that decreases our commercial margin. Some of it, of course, can end up on the Medicare cost report, but it's a big consideration in terms of our managed care agreements. And then travel and acceptance patterns. If we have additional centers flying into our OPO for livers, hearts, and lungs, that means we're flying out more often. And so are we accepting everything that we can locally to avoid flying? Are those organs as good, or are they more marginal or better compared to what we could get elsewhere? And that's always a tough consideration when making the clinical decision of what to accept. The other issue with that is, of course, the availability of surgeons or procurement surgeons that are within your program. And if we have a bolus of donors, both locally and peripherally, do you travel to take a look at something knowing that you likely may come back empty-handed? And how does that affect your ability to potentially have taken that local organ here? And that's always a great consideration. So you're not taxing your surgeons, and in your thoracic programs, especially where they have cases that are not transplant related, how does that affect their normal case schedule that they may have had? Next slide, please. So staffing challenges, and I pose a lot of questions here, and the reason being is because this is, I wake up in the morning asking myself these questions, go through the day asking myself these questions, come home at night asking these questions. And so trying to get across that, trying to find that efficiency operationally is really critical to ensuring that the clinical teams and our surgeons and physicians have the ability to realize the opportunity that is brought to them on a daily basis. And so I think waitlist management, particularly in kidney, as you've seen around the country, really grow and develop. Prior to 10 years ago, most of the programs were eval and waitlist coordinators all together. And what I've seen, significant efficiency in growing waitlist teams that purely manage your waitlist. And in the extrarenal organs, it may be, depending on the size of your program, less relevant, but thinking about now in liver redistribution, do you really need to be looking that deep? If you just listed somebody who's maybe 20th in your blood category, do you really need to manage them the same or different than you would have before? And so, are your patients really ready for transplant is a critical question. So to give the clinical team the ability to dig as deep as they possibly can in order to maximize the opportunity of every organ that's presented. And really, how well do you know your patients? If we're listing in a liver program and they're close to the top of the list given their acuity, we know them pretty well, but in a kidney program, you may not. If you have an average wait time of 5-7 years or even 10 on the West Coast, how do you manage those patients to success when they get closer to the top of the list is a really important conversation to have. And simply listing them, seeing them 4 or 5 years later may not be the best opportunity for those patients. You want to manage the heart disease associated with BM dialysis and so forth. And so I think that for us to really weather this new paradigm, understanding your wait list and having a very confined waitlist management team in your programs is going to be very critical. And then really surgeon availability, both in terms of your ability to optimize organs from a travel perspective, but also what can your center afford to be doing when you have boluses of donors. That's often the ebbs and flows, within the donor population is you'll get 10 offers, one day, and the next week you may get 4 offers all week. And center size really has considerations if you have fellows or if you don't have fellows. Do you have procurement surgeons in various organs? And if those thoracic procurement surgeons that you may have, are they able to also do abdominal procurements when your fellows are out procuring as well? I think one of the worst things we can see happen is that your fellows are doing a lot of procurement but aren't able to participate as much in the cases themselves once they bring the organ back due to those boluses. And so thinking about what's your availability, what's the right thing to be doing local versus on the periphery within those multiple donor opportunities. Next slide, please. So one of the biggest ways that we've been able to create a little bit more efficiency in a program that really has doubled our transplant volume over the last several years is to create an internal organ offer call team. And a lot of this was important in terms of the growth and development of our nurse coordinators within the various programs, the focus being on abdominal at this time. What was the opportunity to maintain their level of staffing within the programs, yet not have them be on call at night, not have them be on call during the day? And how did that look from a financial perspective on top of the efficiency? And so, we chose to build a call team of 6 individuals that had a connection with our quality team and our clinical director to focus on creating a much more protocolized process for which we could algorithmically work through patients that minimize the number of interactions with our surgeons in the middle of the night, minimize as much the interactions with our OPOs, because our OPO coordinators got to know these folks very well. And it wasn't a different person every day over the course of a month, but following 12-hour shifts that these folks are rotating through with backups there as well. So everybody has the ability to collaborate a bit more efficiently than when you have a pool of, say, 20 coordinators in a given program, working 12 or 24-hour shifts and working with our OPO coordinators, that those handoffs and the messages often can get jumbled when you have a lot of time between the initial offer and placement. And so it's really important for us to have this dedicated team who also, consequently, as you talk about putting perhaps more marginal organs in your patients, that this is also the team that takes the triage calls after hours, 24 hours a day, 7 days a week, and is able to deal with some of the things in the middle of the night and already has an understanding of who these patients are because they've presumably worked with them during the organ offer and the call-in experience. And so many of the labor costs associated with the organ offer call team are attributable to the Medicare cost report. Of course, your percentage, your ratio for a liver program, maybe much lower than your kidney program. But if in doing the analysis, we were able to find it at very close to a break even in terms of the cost. And so we were able to, that cost was really associated with taking the work off of the current coordinators, creating more efficiency with them, additional visits on their side with our patients pre-transplant, as well as post-transplant, and really pulling all of that over into this call team has helped significantly. And then, as my colleagues alluded to as well, looking at your behavior, UNOS has developed a number of reporting tools lately, and are in the continual development process of these tools to understanding what your acceptance behavior is, and having a very small, well put together call team that they are now embedded in our QAPI process and can report out on some of the patterns that they're seeing, talking about opportunities they think we've missed, to have a collaborative conversation with the data about how this process works, to realize every opportunity possible. And I hope that, as we get through this more and more, we can really optimize the behavior and really understand how we're operating. Next slide, please. So the financial aspects to consider with flying out more often, perhaps bringing back more marginal organs. If you look at your average cost of the admission for a transplant patient, more than 25% of that cost is easily attributable to the operation itself. And so if you're bringing back more DCD organs, your case times are likely to be longer, and those are attributed by the minute, costed by the minute. Your ICU stays on the back end may be significantly longer. So for a hospital that typically has done 85% of the livers from brain death, you might be able to avoid 70% ICU admissions and go straight to the floor. But as you bring in more DCDs, you're almost guaranteeing yourself ICU stays within that, which is going to, of course, lengthen your length of stay and additional costs associated with complications in the kidney world, DGF, primary non-function, so on and so forth, that are important things to consider. But at the same time, being smart with, if you're going to increase your DGF rate by, say, 10, 20%, working with your dialysis units to still get those patients out on day 3 and dialyze them in the community versus hold on to them for 6-7 days and dialyze them internally, that can make or break your margin. And then, of course, if you're taking more organs and you're growing your program, as Amit had alluded to, understanding how that affects your Medicare cost report, understand how those costs, those increased costs from a clinical standpoint, are going to change your margins and your commercial payers versus what you're able to attribute to your cost report are fundamentals you need to be thinking about. And really, margin balance with the commercial payers is key. That understanding what your thresholds can be if we accept one additional organ at X margin, is that going to put us further in the black, or could that put us in the red? And these, of course, are not questions that we typically ask as transplant centers, but more on the administrative side. But as we enter, this paradigm, there are things that we should all be thinking about. Next slide, please. So really the upside is maintaining team engagement, having everybody work at the top of their scope, having everybody provide their thoughts into this and their experience into this, and talking about what's working and what's not, and really leveraging your QAPI, I think, is incredibly important. You'll realize additional efficiency and that return on investment that you're looking for and that your hospital system is looking for. Margins are being constricted more and more. The East Coast got hit 10 years ago with, a reduction in managed care payer contracts. Some of the Midwestern centers and West Coast may still have more opportune agreements, but the payers are looking for any way to cut a dollar off of your margin. And so you just have to be very conscious of what that looks like. And remembering that margin is still margin. If you have a positive margin on a case, that is still margin that you should be talking about with your senior leaders. One other aspect of this is that often senior leadership just looks at that margin And what you have to consider is all the indirect costs associated with what gets pulled into a high cost case that you're paying for. You're covering costs that are fixed at an operational level outside of even your own center. And for every additional transplant you do, you're covering more and more of that cost. That is an important thing to be considering, as you increase your volume. But ultimately, more so than anything, beyond the finance of all of this, ultimately a transplant is still a life saved, and that's what we're all here to do. Thank you.
Thank you, John. Thank you, Amit. And thank you, of course, Howard. Can I please remind everyone the Ask Me function is there to propose questions. I'm going to present the first three, one to each of our speakers, and then John's going to take over and go through the rest of the speakers that are on your list, your questions on the list. So firstly, just to Howard, you brought up how there are, importantly, interactions between OPOs, transplant centers, and the donors are becoming more complex. The question I put to you is, how would you design a system to address this and thereby increase, in effect, the total number of the chairs in the lifeboats associated with the Titanic? In other words, what do you think are the basic principles of how we need to move forward with utilizing this more marginal appearing donor?
Yeah, I think that when people talk about increasing donation, certainly there's always a possibility to improve your local donor program. But I have to tell you, it's going to be on the periphery. It's going to be DCDs, and it's going to be older donors over age 60 with hypertension, diabetes, et cetera. That's where the margins are right now. Yes, you might get one, more case under age, 16 or whatever. But that's where the real margins are. If people are talking about missing donors, that's where they are. So they are more complex. What I find ironic about it is that now we're going to share those two more often. When in the fact, what's happened in the past, you were able to get those organs used when you limited cold time and could use them locally. So I think we have to look at how the allocation system has expanded and whether that's in the best interest of utilization. And I understand that we have to make sure that critical patients get transplanted. But if it was me, and I'll be outspoken about it, we should have gone from regional share 35 to broader share 35 and tried that, not going down necessarily to a MELD of 29. Because if I have a MELD of 29 here in Philly, and Baltimore has a 30 in the same day, the same donor, why does it go to Baltimore instead of here because of one MELD point? So there are some things I think also we talked about is getting better screening tools, so we're not offering organs that you will never take. And I think both of the speakers alluded to that, not getting offers you're not going to use. Those are my thoughts.
Thank you, Howard. Amit, so a question for you is probably an extension of the question that I just gave to Howard. You talked about intelligent design teams so that you can utilize these organs on the margin. Can you tell me about the characteristics of, you put a job offer up these days and you get 50 applicants. How is it that you're finding those members of that team? What are the characteristics of those team leads to make it effective for you to have an intelligent team design?
Well, I think that, great question. I think that when you're looking to design that team, you want to be bringing in people that are pretty like-minded and that are going to fit into sort of the box of the culture that you have. So in our program, our surgical group, we're all multi-organ transplant surgeons. We all take equal amounts of liver, kidney, and pancreas call. Our most junior person takes the same amount of call as our most senior person. So we have a very flat culture. And so we're always looking for people to really be able to fit into that. And also I think that, certainly the quality of training to ensure that they are able, technically to do that on the surgical side, I think is really important. But I think adaptability is really important. Personality-wise, people need to be open to doing things that they may not have been trained to do, and learning from their peers and colleagues about, this is something that can work. You may not have ever done it before, but it can work. And so not being closed to that. I think another important feature is making sure that people are work well with others. I mean, it's sort of like the kindergarten sandbox thing, but it's not to be understated. I mean, there's a lot of pathology in the transplant business, but I think that it's important to have people that get along in the sandbox well. I would say, in terms of our recruitment processes, they're probably some of the most intense that I have ever seen. Even for positions that you wouldn't think need 20 interviews, there's 20 interviews literally.
Thank you.
Sure there's affable people.
Okay, so they're very important principles. And John, I need to put to you an important question in the theme of what we're doing with this meeting. So let's imagine you have a crystal ball, and we know that change is a certainty. What do you think is the most concerning change that the transplant community, either at the OPO or the transplant center level, will encounter? And what principles would you use to guide us to address what you anticipate to be that most concerning change? How do we address it?
I think from my perspective, the most concerning change would be our center is going to continue to get the support from their hospitals and hospital systems as they see margins decline, with taking more marginal organs and having longer lengths of stay and ICU time, and in particular, I think, 2 readmissions. These are metrics that are being watched very closely, and they're being watched against our partners in orthopedics and general surgery and other areas that, they're, like many of us, have realized their opportunity days, but we're always going to be a bit more on the pedestal and the spotlight because we're such a high contribution margin service. And if you're eroding that contribution margin quickly, then that's going to fall on all the other services that don't have the ability to make that much margin. So we truly affect, especially the larger centers, we truly affect the overall picture of the hospital's finances. And as you saw during the early days, the first surge of COVID, some hospitals probably had erosion into the red because their transplant centers slowed down or even stopped transplanting, even though other services may have continued to some extent. So I think from my perspective, continuing to have everybody understand what your books look like and ensuring that your medical surgical leadership is more of a part of that discussion than ever, to understand how the hospital is operating. We all have different ways that we're organized, but I really do think being tighter with senior leadership is going to be important, so they have an understanding of how to invest, what your goals and objectives are, and where you see yourself being in the next couple of years.
Great, thanks, John. Thank you, everybody. We're going to now transition to some questions from the floor. There have been a lot of good questions, and if they're not answered now, we'll try and get them to you. One question, perhaps for John and Howard, is what impact has been the impact on local recovery for the costs associated with transplant programs? In short answers.
Go ahead, John.
Our location is a little unique, in distance to other areas, but our costs have gone up significantly in our thoracic programs because we're not recovering locally nearly as much. I'd say the same in our liver program as well, although we haven't been hit as hard. But we see others coming to our recovery center more often, and so that's going to require us now to go out. I do think having a recovery center is brilliant. it reduces our costs pretty significantly. It's only 4 miles away from our center, close to our, our other centers in town. And that allows us to control the cost. And we're also blessed to have an OPO that, I know a liver's a liver regardless of where it comes from in the country because of how they pass that cost through to us. So it's easy for me to manage it than maybe in some other areas of the country.
Howard, what do you think, particularly with the context of a local recovery surgeon?
Yeah, we have a local recovery surgeon, which helps get every organ recovered. But in general, when we have a system that blends the import charges, which are typically higher in our region than what we charge our local centers. So they actually benefit, the transplant centers benefit greatly from the way we centralize all the organ acquisition charges. But in general, costs are going up, particularly for the extrarenals, and actually then kidneys are somewhat stable until next month when it all changes.
Great point. As you said, the different finances are a big problem. It's also interesting what the local question means. I think for Amit or myself, it means not flying out to some other place that is versus the local recovery place for different parts. Stu Gunderson next has a great point and comments. You guys have all done a great job of highlighting the individual components, where the efficiencies are, where there's room for improvement. What are your thoughts about how to combine this, the Transplant Center, the OPO, and UNOS, to synergistically have them align? There's still cross. What do you think the mechanism is there for that?
Divine intervention is what we need.
So, all right. So with that, we'll go to Amit.
At least pretty close to divine intervention. But I would say that I think everybody needs to understand each other. They need to take the time to understand each other's issues. And I think that, Howard brought up late reallocations, for example, which are becoming more and more common because programs are holding, lots of offers at the same time. You have to understand what the OPO is going through, and the OPO has to understand what the Transplant Center is going through. And UNOS needs to provide tools to make that work more efficiently. I think one of the CAP program, Accelerated Placement program that has come out recently is a great innovation. It moves late allocation quickly. So I think we need to have more understanding of each other, both in individual interactions, but also as a community to make the system work better. But I mean, not just lip service understanding, really understanding and helping out the other side.
John, any comments?
Yeah, I think just to tack onto that comment, understanding each other is so critical, but also just accepting the differences between philosophies and knowing that we're all here for the same mission, and that it's not always going to work out perfectly, but we need to learn from each other and keep pushing.
John, can I quote a famous person named Rick Hawes?
Yeah.
We need more rules and more tools. That's what we need.
I thought you were going to go with one of Rick's quotes about his boss, but that's okay. So there are a lot of questions kind of around the noise part you mentioned, Howard, with the 110-1 kidney offers, 50-1 liver offers. I think we've covered that. Anyone have any ideas about how to decrease the noise and increase efficiencies that haven't been mentioned already?
No, I think the transplant centers have to do truth in listing. You really have to say, this is what I'll accept for this individual patient, instead of saying, I'll take it all.
And what do you think the limitations are there currently? I mean, somebody brought up, as you know, the DCD we can't necessarily change.
I don't understand.
Like the DCD mileage constraints, for example, or there's inability. We're limited by our inability to put two if-then statements.
There's a lot of improvements that can be made on how we make the offers, no question.
Excellent.
I would say that I would agree with on the transplant program side that programs need to truly be honest. Not just with themselves, but with UNOS and with OPOs about what they're willing to accept. Because whenever, like with this accelerated placement program that happened with kidneys, programs wanted to opt in, but they never really were using those organs. And so if they were never really using those organs, then the time to go through that program's decision-making is added cold time on a kidney or on a liver, whatever organ you're talking about. So if you're never really going to intend to use it, then opt out. But if you're really willing to give it a good look and actually try to use it, then that's a different conversation.
Okay. The next question is from Kevin O'Connor for Amit and John. With broader organ distribution, perhaps better technology, including the ability to look at organs remotely in the operating room, what do you think the barriers are to a local recovery surgeon paradigm? That is specifically a distant surgeon not affiliated with your program recovering organs from you. We'll start with you, John.
Yeah, I think trust. I think it's that simple answer, trust. And I think, as we've been sharing kidneys across the country in paired exchange, we've seen some times where, the organs that are sent to us aren't as pristine as we would have liked them to be. And I think that has limited us a bit in this context. And so I think continuing to build trust around the country, and I hate to say accountability, but that has to play more of a role.
Great. Amit?
I think it's trust plus logistics. So you have to have some ability to understand who's recovering for you and be able to speak the same language. And I think that's incumbent on the Transplant Center to interact with that procuring surgeon in advance of the recovery. We do that routinely. But the other is logistics. So remote donors come with travel time. So having planes in place that are going to facilitate and shorten cold ischemia time is really going to be important for non-renal organs.
Great. With one word answers to this last question, and Howard did a great job of highlighting the disparities and differences across program. If you had one area to standardize across the entire system and to add efficiency, what would that standardization be? Howard.
Oh, I think the concept of patients, the number of patients waiting for an individual organ versus a geographic circle.
John.
I think accountability in the behavior of how we manage offers in general and what we're willing to accept and not willing to accept to speed up the process.
Amit.
Logistics.
Great. Thank you. Thanks, everybody. Very great discussion. We'll try to get to the questions that we weren't able to answer as well. Next, we're going to transition to the afternoon Success Lab breakout sessions.